kind of wait a little bit. So I'm Chris Pomeroy, Dr. Pomeroy. So I'm one of the orthopedic adult reconstruction surgeons here at OrthoIndy, specifically hip and knee replacements. So that's what we're kind of talking about today. So hip and knee problems, more so with arthritis and things like that. This is a little background on me. So I'm not from Indiana, but I did go to undergrad at IU. So that was kind of my introduction to the state, I guess. And then went back home to Louisville, Kentucky for medical school. So not too far down the road there, a couple hours. Then over to Cincinnati for my residencies. So orthopedic residencies are 5 years of training for orthopedic surgery. So I was there for 5 years. And then you have the option afterwards if you'd like to go do a fellowship, which is a 1-year specialty training and a subspecialty of orthopedic. So I did hip and knee, kind of complex reconstruction surgery in Charlotte, North Carolina for a year. And then I moved here in 2015. So I'm in my 10th year now. So family here, I've got 3 kids, 2 girls, boys. So we're settled in now. But affiliations there, obviously hip and knees, part of the Indiana Orthopedic Society, and then board certified, which I would think most of the surgeons are. We've got several other total joint surgeons here, so I'm not the only one. Obviously, it's a big operation we've got going on. I think there's probably about 7 or 8 of us, a few of us around here on the north side, some south, some over on the west side. So there's several of us, but we all kind of do the same thing. So what we're talking about, like I said, first off, we'll just start with knees. Knees are more commonly replaced, or more in the United States, at least, we're talking about, than like hip replacements. So I thought we'd start this. So we're going to talk about, how your knee works and why it can hurt. Causes of pain and symptoms you may feel, or different things people may kind of experience. Obviously treatment options, which is important, and then different questions you may have. So I kind of broke it into knee, and then we'll answer some questions. I also had some of the reps who provide the implants for surgery bring implants if people want to touch and feel and stuff. Everybody asks, how much does one weigh? What does it look like? So there's some, not every size option, but there's different up here if you'd like to see a hip or knee replacement, actually hold it. So we'll kind of get into it. So quick question, how many people in the United States undergo knee replacement each year? And then what disease is the leading cause of disability in the US? Obviously we're not talking about heart disease or diabetes here, so probably arthritis. But as we keep going here, so where's it going? So 660,000, it's even more now, so it's kind of exponentially growing. The population is aging. So hip and knee replacements, it's not like a steady linear increase, it's kind of just going like this. So it's a very common procedure in the United States and really all around the world. And then obviously the answer to the second question there is arthritis. So anatomy of the knee. So the knee is the largest joint in the body. It's often referred to as a hinge joint. So it's not a simple ball in a cup like a hip. Knees can, flex, extend, they kind of go back and forth, they slide, they pivot, they rotate on each other. So it's a very complex joint, so there's a lot of things that can happen to it, a lot of stresses that go across it that can cause pain. There's 3 bones that make up the knee joint itself. There's your shin bone, or your tibia, which as you see there, your thigh bone, your femur, and then also the kneecap in front. So there's actually 3 parts to your knee joint, kind of the inside, the outside, and the front, where people kind of say my pain's here, there, or somewhere else. So in between these, you see the word cartilage. That's kind of the cushion of your knee. When we start talking about arthritis, we're talking about the cartilage wearing down. Then you may hear people say I'm bone-on-bone arthritis. That's when the cartilage is gone, and now the bones don't have any cushion between them anymore, and that's not comfortable. So you have cartilage kind of on all 3 parts of the joint. In this little video, the smooth ends that you'll see kind of on the end of the femur or the top of the shin bone, that would be your cartilage. You can see it goes all the way around the back because your knee has to bend. And you also have cartilage between your kneecap and on the front of your thigh bone that can be affected with arthritis as well. So a healthy knee, if you kind of look at the top right picture there, like I was saying, each end of the bone is covered with cartilage or cushion, and it acts like the cushion so the joint functions without pain. You also have fluid in your knee, like a lubricant, like you can think of kind of any other thing in a car that would move. It has to have lubrication. Your knee makes that. That's how it gets in there. But the healthy cartilage you can see is nice and smooth, and actually when you're looking at it with your eye, it almost looks like a pearl, like a nice smooth white surface. And then you can see the bottom picture there where it start getting more pink. There's kind of holes or gaps in the cartilage. that would be when the arthritis, so when it starts wearing out. So, and how do you get arthritis? It's just kind of normal wear and tear. Everybody as they age, the cartilage dries out some, starts getting easier to wear down. Obviously, if you've had an injury or previous surgery, stuff like that, it can also wear out quicker too. But normal, just primary, we call it arthritis, just run-of-the-mill arthritis is, you get with age, is just over time it wears out and becomes painful. So this is, what is arthritis? Kind of said this, but it's also just kind of known as wear and tear. It's caused by that cartilage breaking down. It gets kind of dried out as we age, just with normal aging. And the main thing I try to tell people in the office is when you get arthritis, there's no shot or pill or therapy. There's nothing that's going to reverse it. So we can't just go put brand new cartilage on the end of your bone. It doesn't work. They've tried it in the lab. The stresses and the motion and your body weight going through it, it just doesn't work. So you kind of, have to keep the cartilage you were born with as long as you can. And then if it's gone, then you start talking about other options. And like I said, it can go undiagnosed because a lot of times people come in with pain, you get an x-ray, and they're like, it's only been hurting for a few weeks or a month. It started a long time before that. It's just now become symptomatic, and it's kind of the needle, kind of the straw that broke the camel's back. It kind of finally started bothering you. So this is a picture of kind of disease progression. So what we call that would be more like arthritis as it kind of gets worse. So, the joint fluid becomes less healthy. The cartilage, like I said, dries out and starts to kind of break down. Pieces of the cartilage and bone can actually break off, and some people get little pieces of cartilage floating around their knee that can feel like something's getting stuck. And almost like having like a pebble or rock in your shoe, but you can't get it out. It's inside your knee. And then obviously bone spurs. So those come as your arthritis gets worse. As the cartilage gets thinner, your body makes more bone trying to relieve some of the stress through your knee. And so it makes extra bone. So those are called bone spurs. So that just comes with arthritis also. So there's another one more like bone-on-bone arthritis. So like I said, as the arthritis gets worse, the cartilage kind of gets thinner, then eventually you can get bone-on-bone, so they may rub together. And those people, like I said, not a lot of options. So eventually they may be a candidate for a total knee replacement. So, causes of arthritis, this is a question. Obviously age, just normal wear and tear. Weight is a factor. And then, diabetes is associated with it as well. Some of the diabetes probably goes along with the weight, so those may be linked, but definitely managing your body weight, lower stress through your joints for your whole body at that is obviously a good thing. Symptoms, obviously knee pain that doesn't really seem to go away, kind of a deep toothache kind of pain, not necessarily a sharp stabbing pain. Stiffness, so when you get up out of bed and you gotta kind of wait till it settles in a little bit before you get moving. Obviously swelling in your knee, arthritis is an inflammation problem, so swelling in the knee can be a sign of it. And then just kind of difficulty doing your normal everyday kind of stuff, going to the grocery store, trying to go up and down stairs, getting around doing your laundry, stuff like that. If your hip and knee start bothering you, it definitely could be arthritis. So different treatments. At first, start with the least invasive treatment, which would be kind of non-pharmacological, which is more healthy eating, exercise, managing your weight, using a cane if it's bothering you, different things, ambulatory aids. You get obviously over into more like medications. You start talking about Tylenol, which is the acetaminophen, or ibuprofen, Aleve. They have creams and gels you can put on. And then obviously there's injections you may have heard of, or you have friends or someone who had one. There's different kinds of injections we'll talk about. And then surgical interventions, some of those obviously bariatrics more for weight. Debridement, they used to go in with cameras and try to clean up arthritis. You don't really do that as much anymore, just because if you go in and take cartilage out with the camera, and the definition of arthritis is losing cartilage, then you're kind of making it worse. So it doesn't really do a whole lot. So then kind of at the bottom there, joint replacement. If you've tried everything and it's just not working and your quality of life is kind of going like this, then you may consider a hip or knee replacement. So non-pharmacological, we just kind of went over weight loss, therapy, using a cane or a walker. And the medications. So over the counter, you can use, like we said, Tylenol. And then some of the anti-inflammatories, ibuprofen, Aleve, or work better for arthritis than Tylenol just because it's an inflammation problem, so anti-inflammatories should work better. The problem is not everybody is supposed to take anti-inflammatories, so if you have kidney problems or you're on a blood thinner or blood pressure medicines, so you got to talk to your family doctor who knows you much more than I would because you see him every year, and you can ask him, am I allowed to take anti-inflammatories? So that's a good question to ask them. Like I said, Tylenol on the left there, the active ingredient is Tylenol. It's kind of a pain and fever reducer that goes out through your liver. The other ones, the anti-inflammatories like ibuprofen, Aleve, those go through your kidneys. That's why I mentioned the kidney thing with your primary care doctor you may have to ask. And these are all, reasons to use over-the-counters. I don't know if you need that much reason. People, Tylenol is pretty available anywhere you go, ibuprofen everywhere. So obviously a lot of people take these. Once again, I would talk to your family doctor about some of the anti-inflammatories. Getting to the next step, which is when you'd have to either your family doctor or probably go see more of an orthopedist, so you start talking about injections. So steroid shots, everybody's heard like a cortisone shot. So cortisone is just a generic name saying I got a steroid. That doesn't mean it's the specific steroid they gave you, it's just I got a steroid shot. Those are anti-inflammatories. It's like putting 100 ibuprofen inside your knee. That's what it does. It doesn't go to your kidney, so even people with kidney problems, blood thinners, you usually can still get injections just fine. You can do them every 3 months, so up to 4 times a year. It doesn't fix anything. The whole thing is trying to make it feel better. And over time, they tend to not work anymore. So the benefit of them over time goes like this. Some people, they get one, doesn't work. Some people do them for 5 years, and then they stop working. Some people can't have surgery, so they do them for the rest of their life because that's their only option. So injections are definitely an option. The HA injections down there at the bottom, that's more like putting WD-40 in your knee. It's a viscous supplement that you put in. It's like a lubricant, so it's not an anti-inflammatory. You inject it in, and it lubricates the end to try to make things glide better. Those are usually more every 6 to 8 months because you got to go through insurance companies, have to approve and tell you what we can and can't use and things like that. But the HA injections, it's a normal thing you find in the joint fluid in your knee. So it's, like I said, just kind of putting more lubricant inside your knee. There's a little detail, but there's OrthoVisc is just one of the brands. Some of them you do all at once. Other ones I think are a little less painful, I guess, would be we split them up into 3 injections. So say you come on a Wednesday, and a Wednesday, and you do 3 in a row, just so you don't get all that thick fluid put in at once. It's less pressure in your knee, so it can feel better or not hurt. I guess some people say it hurts if you get all of it at once. The monovisc, this is what I was talking about, is one bigger injection. So we usually kind of lean towards the 3 injections. So then we start talking about, obviously, surgical options. So the implants, the whole point of an implant, or a knee replacement, we're not taking your whole knee out and putting a whole fake knee in. All we're doing is resurfacing where the cartilage is lost. So it's really a resurfacing procedure is really what it is. So when you get done with a knee replacement, your own ligaments still make the knee stable, your own muscles still make it work, your own nerves, arteries, everything still make your knee and your leg work. You just have new artificial surfaces on there. So like I said, there's more than 660,000 a year now. It's probably more like 750, but it's a very, very common procedure. So that's kind of a picture of an implant. Like I said, I've got some models up here we can kind of pass around, but so it just kind of removes the damaged ends and surfaces of the bone and replaces them with metal and plastic, essentially, is what a knee replacement and a hip replacement is. So how does it work? Like I said, you put a femoral component or on the end of your thigh bone, the top part, that would be number 1. The shin bone piece would be number 4. So you kind of make a new platform or kind of like a kind of scaffolding for your house, you would think. Or, you put that on the top of the shin bone would be number 4. Number 3, it's kind of hard because the color, but it's actually a piece of plastic that you slide in between the 2 pieces of metal, and that acts like your new cushion. So there's metal, and then plastic in between. And then number 2 is your kneecap. We put a little piece of plastic on the back side of that. So you actually end up with 2 metal pieces and 2 plastic pieces in your knee if you have a full knee replacement. So here's kind of X-ray example. So on the left, there would be kind of a healthy knee. You can see how the end of the bones, everything's nice and smooth and round. There's nice gaps in between there. If you ever see a doctor and they say, I can see your cartilage on an X-ray, they're lying to you. You can't. You can only see bone. but you look at the smoothness and the gaps. So if it's nice and smooth, that's good. The middle one, obviously, not smooth, gaps, it just looks like you're looking at a cloud. That's all arthritic. There's a bunch of arthritis in that knee. And then you go over here, and that's now been replaced. So the metal pieces show up as white on an x-ray. So everything that's bright white on the right is metal. The plastic you cannot see on an x-ray. That's why it looks like there's a gap in the middle with nothing in it. So that's a knee replacement on the right. And you can't see the kneecap because it's in front of the metal piece, and the metal's brighter white than the kneecap, so you can't see it. So, should you replace, or should you wait to replace your knee? Right now in the United States, I'd say the average age of a knee is probably around 64, 65 for a knee replacement. There's different reasons for people to get them earlier. Obviously, people wait later. So, when should you do it if that's like the last option? Obviously, it's a quality of life surgery. It's elective. There's never an emergent knee replacement you have to go do because it took many years for you to get a bad knee, so it doesn't have to be fixed tomorrow. So, how severe is your pain? What do you like to do in life that you can't do anymore, or you can't go on walks with your spouse, you can't enjoy things, or your kids, or whatever you're doing? Driving, walking, stair climbing. If you're taking the medications or you've had injections, they're not working anymore. Maybe it's time to keep going down to the next step, and that could be a knee replacement. Obviously, if you answer any yes to this, you can obviously go see me or someone, but you can talk about knee replacements to get more information. Early diagnosis is obviously very important. You don't want to lose good quality years of your life if you could have been getting treatment that would make your knee or your hip feel better. And then obviously we said osteoarthritis is degenerative, meaning it's not going to get better on its own. It will slowly, progressively, just slowly get worse. So you can't put new cartilage back in there and it doesn't grow back, so it slowly gets worse. And then rehab and recovery. So I will tell you, after a knee surgery, the knee replacement surgery, the surgery's less than an hour, 45 minutes for an hour, not too long. The physical therapy or rehab you do afterwards is going to make the knee replacement work or not work. So you have to have good social structure, kind of mindset, goal-oriented. I want to get the knee better after surgery because it falls back on you as the patient. If you have a knee surgery, to do the therapy, to go to therapy, all that kind of stuff. So it's a good 6-7 weeks of physical therapy afterwards. We like you to go 3 days a week, 2 to 3 days a week. Obviously, the goals of the rehab, I tell people the first 8 weeks, we want you to get your leg to go straight and get your leg to bend all the way up. If you can do that by 8 weeks, you should be good. The strengthening part happens with time. That's okay if that takes time. That's your muscles just getting used to the implants and getting going. But the motion you got to get before scar tissue and all that kind of stuff makes it stiff. And obviously, you can return to most of your normal activities. I wouldn't pick up marathon running after getting a new knee replacement, but you probably weren't doing that before if you're getting a knee replacement. Definitely low impact, but people are skiing, softball, golfing, kind of walks, hiking, whatever you normally kind of would think of as a lower impact exercise. So, how do we close the incision? Some people ask. Here, I would say probably we all use glue now, so there's no stitches or staples to take out. All the stitches are underneath the skin. They're dissolvable, so you should never see them. You get a rubber Band-Aid on your skin, which we all use the same dressing. You can shower the same day you go home. It stays on for 2 or 3 weeks. You peel it off, and then you just let the glue fall off. So it's pretty low maintenance on the incision part of it. Really, your main focus, and the one thing we ask you to do is just do your therapy. That's really the main goal for you. They used to use a lot of staples and stitches, so people, if you see someone with an incision who had an old knee replacement with staples or stitches, it looks like little railroad tracks going down the side of it. Now it just looks like a nice smooth straight line because everything's under the skin, so it's all hidden. And then obviously is a knee replacement for you. Does your knee hurt, more than a couple days a week? Is it pain waking you up at night? Can you not sleep? Everybody needs to sleep. Does it hurt more to walk more than a block? Pain medication's not working anymore. And then once again, family vacations, is it limiting, your activity, your quality of life? And then have you been gaining weight because of your knee? Are you not, I used to exercise, but now I can't. So the weight gain's gonna affect everything else in terms of, heart and kidneys, all that kind of stuff. So here's just a few little things, walking, bending, acting like you're driving, moving your leg around, swinging a golf club. Different things. If you can't do that, things you enjoy anymore, then it could help you. Kind of in summary for the knee talk, it's the leading cause of knee pain is arthritis, other than trauma things. It's degenerative. It's not going to get better on its own. Like I said, early diagnosis treatment can definitely make your life better, and it can be important for just a long-term outcome. 95% of people are happy they got a knee replacement once they've recovered. A lot of them say, I wish I would have done it sooner once they've recovered. I will tell you the first couple of weeks, you're not going to tell me you wish I would have done it sooner, but once you recovered and done therapy, then yes. And then, they come in all shapes and sizes. Like I said, I've got a couple models up here. They come in all ranges of sizes. There's wide, there's narrows, there's taller ones. The plastics go, 5, 6, 7, 8, 9, 10 millimeter, 12 millimeter, 14 millimeter. So everything's catered. And when we do a knee replacement, we size everything during the surgery so it fits your shin bone and your thigh bone. So everything's kind of personalized. And you could get one on one leg that's different size than your other leg. Doesn't mean they're going to be the same. And then some references. But do you guys have questions about knees?
How long would you expect to have a knee last?
So a long time ago, so that's a good question. So it used to always fail when people started talking about why do hip and knee replacements specifically fail. The plastics weren't good. So the plastic that you put in between, like a knee replacement, in 2000-ish time area, the government got involved because the companies were just kind of randomly making these, and they just broke down very quickly and caused big problems with the bone. So once they got involved, really after 2005, they got way better, and now they're better. Most companies are saying they should be at least 20, 25 years probably. So if you get into, and I've seen people who are 30 years, I didn't do their surgery, but they come in. So it can last. That's why if you're into that, really I tell people if you're over 60, you probably should never have another surgery on your knee with a knee replacement. If you're in your 30s and you had a traumatic car accident and you got a knee replacement, there's a chance you might have to redo the plastic or something just because they're going to live longer if they're only 30-something years old. So I tell people our average around 25 years. Oh, who was first? Yeah.
You mentioned after you have knee replacement, can you play basketball?
Sure, people play basketball.
Yeah.
Mm-hmm. Yep, people are, like I tell people, I wouldn't pick up running. There are people who go jog. I don't recommend starting that as your new hobby, but if you're already doing it a lot and you're kind of doing different activities, walking. The big things we tell people, walking, whether it's outside a treadmill, anything on a bicycle, because that's low impact, whether it's stationary, recumbent, or outside. Ellipticals are good because your feet are planted. That's a good cardio. Anything in the pool, so water aerobics, swimming, and that kind of stuff. If you're getting into more like hobbies, activities, then sure, if you enjoy playing pickup basketball one night a week or something, yeah.
So when there's pain in the back of the knee, since it's the knee, why is there pain in the back of the knee?
So a lot of times people get pain in the back of the knee. If you get arthritis, if we're talking about arthritis, and you get swelling in the knee, a lot of times it feels tight in the back of the knee because it kind of pushes on that. That's where your nerves and stuff are in the back of the knee. So it hurts in the back part of your knee. It's called your popliteal space, but it's back under here. And then when people go to straighten it, it feels like you may have a cyst even, but you feel like something pushing out back here. So a lot of times it's from the swelling. The arthritis can go all the way around the back of the knee, but there's really those three compartments, the inside, outside, and the front. There's not really a back part because your knee doesn't hyperextend this way, either bends or, but the back's usually from swelling. Oh, I think she was next, maybe.
How complex is it to replace a knee partial replacement?
That's considered revision. I do a lot of the revisions here. It's not, I guess, that complex if you do it a lot. But definitely, I will tell you, if you look at outcomes, just saying, I'm very picky on who gets partials. The lifespan of a partial, which when she says partial knee, that means you either replace just the inside part or just the outside part or just the front part, so not the whole thing. If you do a partial, it's usually not the partial that fails, it's the other parts of your knee get arthritis. So then they start hurting. So then when you have to deal with that arthritis in the other parts, you don't give people two partials, you switch it to one full one. And that, you have to take the pieces out and then put in a full one. The time of the surgery, honestly, is not that much different. I don't think the recovery is that much different. If you Google it, it would say the recovery from a partial to a full is not as successful as just one full. So the least amount of surgeries you can have, usually the better.
So when you have the swelling in the back, is there like a way that you can just have your leg to kind of reduce that swelling? I mean, is it ice pack? Is it just
so that's what
elevated?
Yep, so the anti-inflammatories can help obviously with inflammation. Ice definitely is better than heat for inflammation. They do make anti-inflammatory creams. I didn't put it on here. There's like Voltaren gel. There's commercials all over the place for that one. You can also, like when you get the steroid shot, the cortisone shots, you put that in the knee. That helps get rid of a lot of the swelling in your knee. There are some doctors, if you're really swollen, they'll actually pull all the fluid off your knee first before they put the steroid in, just to take some pressure off. So there's different things you can do for it. The thing is, the swelling will come back. It's arthritis that's there until you take it out. So. Yep.
Yeah, I went to a gal who did some myofascia on my knee.
Yep.
Didn't really help any, but she gave me this list of exercises to do, and I like to hold them in place for a minute 30, work your way up to like 5 minutes. She said there's a mesh around your joint that you want to make sure that it entraps your joint. Does that sound familiar?
I mean, I'm assuming she used it, or he or she used the term mesh as your joint capsule, like what
Yes.
surrounds your whole knee.
Yeah.
Because your knee is one big space, even though there's 3 parts of it. I'm not as familiar with trying to hold it in one spot. Generally speaking, we tell people try to stay mobile, keep moving it so it doesn't get stiff.
Yeah.
So we always tell people, even when you get a knee replacements like to be used. We want you to keep moving, keep doing stuff. So I'm not as familiar with what, now they do, like therapists can do scraping and different ultrasound techniques. They do all that back over here too. But I'm not as familiar with someone telling you to hold your knee in one spot for a minute, then 2 minutes, and 3 minutes. I'm not
She
sure.
told me, some positions it's really gonna hurt you, like bending my leg behind me.
Mm-hmm.
Oh, that killed me at first, but now I work my way up.
I mean, you may have loosened some things up, honestly. Generally, bending your knee, if you have, I'm not sure, but if you have arthritis in your kneecap joint on the front, when you bend your knee back, the kneecap just gets pulled harder and harder and harder into the front of your thigh bone. So if you have a lot of arthritis in your kneecap, people trouble going up and down stairs, sitting in like a low chair. If you're on an airplane for a long time, then you get up and you're like, oh my gosh, the front of my knee. So that's all like kneecap arthritis.
Okay.
So maybe that's what you have if the front of your knee, or if it's hard to bend, might be.
Is it recommended to only do one knee at a time, or do people get them both?
So you can do 2 at a time. That's becoming less and less popular. We used to do that more. There's a couple reasons. Obviously, the biggest reason is complications afterwards. So the risk of like a blood clot, the risk of infection, obviously bleeding risk, stuff like that that goes with any surgery. They're not just like, if it's here for one knee, you would think it's just like double for the next knee. It's not. It's like triple, quadruple. It's exponential. The recovery is a lot harder too, because you're like trying to rehab both knees because you only have a certain amount of time to get your motion, and you're trying to do it on 2 instead of 1. With that being said, there are people who come in if they have really bow-legged or knock-kneed, or they can't walk because both knees don't go straight or whatever. Doing one wouldn't help because they couldn't walk anyways because the other one's so bad. So sometimes you do, for medical reasons, need to do both. But a lot of times we stick to just doing one. I like to wait at least 2 months in between knees, just so you're finished with physical therapy. This one feeling okay. Now you can rely on that one when you start doing therapy on this one. So they used to do it where they would do one and keep you in the hospital, and 4 or 5 days later do the other one. That was not a good idea to try that. That's what they used to do. People had all kinds of complications, blood transfusions, all kinds of things. So nobody does that anymore.
What's the ideal minimum gap between one and two knees?
I wait at least 2 months. Some people say, I say some people will be like, I'm going to wait till next fall. I'm going to wait a year. I just make sure it's at least 2 months. I don't know if I think once you get past the therapy on the one and you're feeling comfortable with it, I don't know if there's an ideal time range. I think it's just, you don't want to do it too close together. I mean, there is definitely a recovery phase. And I don't know if you've talked to people with knees, anybody you talk to would say a knee replacement recovery is harder than a hip replacement recovery. Hip replacements, you get it. A lot of people go home the same day. You're up walking within 5-6 weeks. You don't even have to do physical therapy. In like 5 or 6 weeks, you're usually cruising around pretty good. Because the hip, once again, I told you, the knee has all these different ranges of motion. The hip is a ball sitting in a cup. So they don't get stiff. They don't do anything. So. So yeah, so everybody's hips are hurting now, right? Not their knees. Yeah.
Can knee arthritis cause a shin splint pain?
If it's bad enough and you get down to bone on bone, you can start getting radiating pain in the shin bone. So yeah. Now, like only in the middle of your shin would be not normal. Like if it's up towards your knee joint, like where the bones were rubbing, that would be more common. It could also be if you're walking differently or limping or your posture's off. I mean, there are people who be with bad hips or knees, and because they hold themselves, then they get sciatica or their back starts hurting and things like that. So.
I have a list of questions.
Okay.
If anybody else wants to jump in. Okay, so the double, how much does the age play?
Double, so for doing 2 knee replacements at the same time. So it's not even up to me. Here at our facilities, we have a cutoff of the age of 60. Because to do both knees at the same time, you have to be 60 or younger. And then obviously from a medical standpoint, you got to be healthy too. But the age you asked is 60 now. And that's from our own medicine doctors who do all of our, like if you're going to have a knee surgery here or hip, you have to meet with we have you see our own medicine doctors, and they go do all the pre-op work. And they told all of us that 60 is what they're comfortable with.
Is there a better prognosis the younger you are for a double?
I think recovery is probably a little easier just because you're probably more mobile, and I'm guessing maybe more motivated because you're trying to get back to work or who knows what you're doing. But I would say probably if you're younger, then yeah, you get moving quicker. A lot of it has to do with more so how mobile you were before, because there are definitely some 40 or 50-year-olds that are not very active, and then there are some 70, 80, 90-year-olds who are running around doing everything. So it's probably more related to activity level before the surgery, more so than just your age.
So what about before surgery, if there is, you showed the pictures of the knee that was totally arthritic. Do you have to go in and clear out any of the arthritis before?
We take all that out while you do the surgery.
Okay.
So it's one surgery that takes all the arthritis out, takes all the bone spurs out. You take out, we didn't get into it, but your meniscus take out, your ACL ligament you take out.
So if there is a cyst,
Cyst goes away. You take all that stuff out before you put the implants in.
and what if there's a bone bruise?
So a bone bruise, if you're bone on bone, you get bruising down into the bone, which you cannot see on x-rays. That's more with MRI. That is probably more so because you're rubbing bone on bone. So that would go away once you replace it, the surfaces.
Do the replacement?
You can still do it, yep.
So you said 30 years, and then you may, like, what are the symptoms? How do you know it's failing if you have replacement?
If you start feeling like it's feeling, I guess, if some people come in if they have, when they feel like feeling more wobbly, just because usually if you put a whatever thickness plastic in, and over time it's worn thinner, it may feel like it's got a little like wobble to it, like instability. So instability would be the most common reason.
So you would like,
And the plastics are modular. So you can go in there, when I say you may have to do something, you can go in there and just take the plastic out and just put a new piece of plastic. You may not have to touch any of the metal pieces or do anything. You just pop out the plastic and put a new one in. It takes like 5 or 10 minutes. But that may be having to redo something.
okay.
So it doesn't mean you have to redo the whole thing.
What's the minimum age for a total knee replacement?
That is hard to say. I've done them on 20-year-olds. I've done them on 90-year-olds. So there's not really a minimum age. It's more so what treatments have you done? How long has it been bothering you? Those are the main things. I mean, what x-rays look like. Most of us, you don't need to go get like MRIs and CT scans. None of that's really necessary. Usually you can just see it on an x-ray.
And if you have all that testing from another place,
Yeah, you don't have to redo
bring
it.
it with you.
Yeah, the only thing we may do, I know at least in my practice, if your x-rays are over a year old, you may get some new ones here just to see what it looks like now. But if they're within a year and we can get them to load up on our computer, usually I don't redo them.
If you have an MRI already.
If you have an MRI, yep, we can look at it and obviously talk about it. If you can see all the arthritis on your knee, I would have said I probably wouldn't have ordered the MRI just because you can already see it on the x-rays. So
So what are the chances, because if it's not showing on the x-ray, but the MRI says,
it can surprise you sometimes. Like if people are, if you're treating people, pills or shots and creams, and it seems like their symptoms are not super, they're not going along great with what I'm seeing on the x-rays, and you could order an MRI just to say, are we missing something? You can do that, yeah.
Pre-therapy, do you recommend that?
So there's prehab, that's, yeah, so some people not make you, but some people do physical therapy before surgery. We used to do that. That was, when I did it, it was for two reasons. One, it was either because the insurance made us do it, or two, if someone's like in a wheelchair and I'm about to replace their knee and then tell them to get up and walk the same day with therapy, it's probably good to have them try to do some before for strengthening and such. If you're working, walking, still trying to get through everyday activities, going to the grocery store, for me, I don't make people do it before.
So you say 3 times a week for 8 weeks therapy.
That would be on the long end usually, but yeah, it's usually, 6-7 weeks, but yeah.
How does that interfere with work? Like, could you work from home?
There are people who work from home. If you work from home, some people go back to work the next week. That's up to you, obviously.
Do therapy all day?
Yeah, no, you're not doing therapy all day. You may go for like an hour session. So there are people who go back to work and then they get a 5 o'clock therapy session to go to after work. So that's not an issue. We don't want you going back to work so quickly that it interferes with you doing your therapy, because like I said, if you don't get that motion that first couple of months, it's not like you can get it later because the scar tissue gets really thick. So you've just got to be dedicated to get the motion at the beginning, and then the strength can come.
What about post-operatively going up and down stairs?
So they make you do stairs here in the hospital before you go home. So you're allowed to do it. I'm telling you, you're not going to want to like do it 10 times a day when you get home. But if you need to kind of stay on the first floor or whatever during the day and you go upstairs to go to sleep, there's a bathroom up there, and then you come down for the next day. People do that. You can go up and down the stairs. You may be, going single leg at a time or kind of sideways at first, but as you start doing physical therapy too, they should try to be getting you to do, reciprocal gait to go up kind of normally, left, right, left, right.
I'm still very interested on this double.
Yeah.
So,
No, it's a thing. It's just not. There's the actual medical reasons to do it, or there's not a ton of them because of the higher risk of complications. So not as many people are doing them anymore, I would just say.
would that impact your ability to go up and down stairs if you had a double?
I mean, if you did both knees, the recovery's longer. I mean, a lot of people, at least when I started here, the doubles I were doing, whether it was right or wrong, they wanted to do it because they didn't want to be off work twice. Yeah. So being off work twice is not worth getting a blood clot that goes to your lungs, something bad happening. Because the risk of a blood clot, infection, that kind of stuff is much higher doing both at the same time. So a lot of the surgeons, at least here, lean towards one at a time. Like I said, I've done doubles. I still do them occasionally. I'll do both hips at the same times occasionally. But you got to, once again, it's just being kind of picky with the people who get them, which means you've got to know a lot about their medical background and all that kind of stuff.
Somebody else can go, sorry.
Is there another knee question? Go for it.
So do you just do the knee and you only specialize in the knee and the hip?
That's all I do every day, hip and knees. Yep. So we've got shoulder guys who do shoulders. We've got foot and ankle guys here. We've got hand surgeons. We've got spine surgeons. We've got all the other surgeons. But the group of adult reconstruction specialists, we do hips and knees.
Because I have arthritis in my wrist, and I have it in my knee, and
Yep.
I have it in the L4 and L5 in my spine.
So you could meet multiple people here. Yeah.
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 What kind of requirements are there before surgery? And you have to lose some weight before surgery.
So there are surgeons with BMI cutoffs, and that's kind of a ratio, between your weight and your height. If you're taller, your BMI goes down. That's just the way it is. But yeah, that some people do have BMI cutoffs just because the risk of infection goes up with obesity and weight. A lot of times weight can lead into diabetes, and blood sugars can cause an increased risk of infection too. So we have a very, very low infection rate here. So that's another thing that goes on with your pre-op appointment next door with the medicine doctors. They check your blood sugars, they check all that stuff. And if it's above a certain number, they'll call me and say, Chris, you can't do their surgery. And I can't change that.
I got another question.
Sure.
too. When you were talking about the actual parts,
Yep.
you said it comes all kind of shaped. and
Shapes, shapes are relatively the same, right? But I mean, different sizes, yes.
So you determine which one
Scary,
go
yep.
in, not insurance.
Oh, no. Insurance has nothing to do with it. Once they say you can have surgery, I get to choose all the stuff we do during surgery. Yep. So the consent form says knee replacement, and you'll get a good knee replacement, but you have no idea what sizes you're going to get, any of that kind of stuff. Most people don't even know what they have afterwards. We have all the part numbers and everything, but most people have no idea what size they have in their knee. They just want it to work.
Yeah.
Yeah. Yeah.
The HA injections.
Yep.
So my orthopedic doctor that have been seeing didn't recommend them.
Okay.
I've done cortisone injections.
So I will do HA injections on people if they still have some space between their bones. So if you're bone on bone and I inject a jelly in there and you stand up, it just gets squirted everywhere else. So if you have bone on bone arthritis in your knee where your pain is, I mean, I would do it if you're like, that's what I want to do, but I don't think it's going to work probably. Yeah.
The sleep, you
Mhm.
also said that it impacts your sleep, so, do you have suggestions? And I've also heard that after a knee replacement, you have to sleep with your knee in an angle?
No, I actually don't want people to bend their knee up after a knee replacement when they're sleeping, because if you sit with your knee bent up all the time, it's going to feel good after a knee replacement because it's not as tight, like she was asking, that pain in the back when it's straight. But if you sleep with it bent up and then you go to therapy and they're like, now you need to straighten your knee. You're like, well, I like it like this. And then if you have it like this all the time, you're going to walk around with a short leg because you can't get your leg straight from your knee replacement. So I like people to sleep with a pillow or whatever kind of calf down to their heel, so gravity's kind of pulling the knee straight and your legs elevated because that helps with swelling. Icing, elevation, and straight's good after surgery. But before that, like if you're talking about now sleeping, anything you can kind of get comfortable with, whether it's, like I said, creams, injections, pills, pillows between your legs, trying to find a good position. There's not a great way if you're bone on bone, because if you start moving when you're sleeping, then it wakes you up because something hurts. You can't really prevent that. And I would not recommend like a knee brace to sleep in, just because then it's going to get stiff. You want to kind of keep the mobility.
What does pain management look like after surgery?
So that's a good question. So you get 3 medicines from me. One would be a blood thinner. Everybody's on a blood thinner for 30 days to help prevent a blood clot. Normally it's just baby aspirin twice a day. It's not like a big blood thinner usually. Second one, we send you some nausea medication in case the pain medication makes you nauseous. You don't have to pick it up unless you need it. Third one would be the pain medicine. So in the hospital, we have a bunch of order sets. There are some people who are on chronic pain medication. They may need something stronger. There are some people who just don't tolerate pain medications. They need something really light or else they're going to be nauseous. So it's really based off for me, what you get in the hospital that I know you're tolerating for that day and a half you're here. Just because I know you've been getting it and you're fine with it. So you're not allergic to it. You're not having a bunch of itching or nauseous, throwing up, stuff like that. So we just send that to your pharmacy too. So you get those 3.
And we do this outpatient.
So the answer is yes. And the question is, well, what do you mean by outpatient? Do you mean same-day surgery or what insurance calls outpatient?
Same-day surgery.
So yes, the answer is yes. Hips are more common, but you can do a knee replacement and go home. We tend to like to have people spend one night, so you're here less than 24 hours, so it's still considered outpatient. So when you do outpatient, generally speaking, with your insurance company, they mean a 24-hour stay, not as much as you can't stay at all one night. So the benefit of staying one day is you do get nerve blocks from the anesthesiologist before surgery. Those last 12 to 16 hours, so they can wear off here in the hospital when the nurses are taking care of you, or they can wear off when you're sitting on your couch at home and you can't get a hold of anybody. So we usually have I like people to stay a night, especially with knees. A lot of people with hips go home. Like I said, hips are easier recovery than knees. But there are obviously tons of surgery centers all over the country that do your surgery and tell you to go home. So you can do it outpatient, which we would call same-day surgery. They do sometimes require you to have prehab, so you learn the exercises before because you're not going to be in the hospital with our therapists, so they want you to get some education before if you're doing same-day surgery.
And you have both hip and knee arthritis to the point where replacements are being suggested,
Sure.
do you suggest one?
I usually start with the hip. I usually start with what's more central. Hips are easier recovery. You can kind of get moving around on it. If you do a knee and the hip's preventing you from walking and your hip and your knee can get stiff because you don't do your therapy, I don't want a hurting hip to prevent you from doing your knee replacement therapy, and then you have a bad hip and a stiff knee replacement, and nobody would like me. So I like you to do a hip replacement because you can sit on the couch and let your hip replacement heal because it doesn't get stiff, and then deal with the knee replacement once your hip's recovered. So I usually start with hip and then do knee.
I've noticed on the screen, you talked about debridement, and you said people don't really do it anymore.
Yep.
Does scraping scar tissue, does that?
So that kind of be debridement. The debridement more is like you hear people do camera surgeries, arthroscopy. So if you're going in there because they have a meniscus tear and they're cleaning up a meniscus tear, they may shave little hanging cartilage that's torn. They may debride some cartilage, but nobody's really doing a camera surgery just to go shave down bone spurs because it's the arthritis that caused the bone spurs. And honestly, most insurance companies won't even approve that anymore. 20 years ago, they didn't know what was going on, so they did. So nowadays, people don't do that for just debridement. You can do it if the meniscus is torn and you're debriding because you're in there for the meniscus and cleaning things up. But in the end, like I said, arthritis by definition is losing cartilage in your knee. So if you go in there and take cartilage out with a camera, you're not really helping the arthritis. You're actually kind of making it become more advanced. So you're not really, it may feel better, but there are studies that show you can do a camera surgery and just flush water through it and do nothing and take it out, and people say it feels a lot better without doing anything. So they don't do that nowadays. They've done that before though. So some of it is just flushing all the inflammation out of the knee with the water, and everything makes it feel better. But I don't do camera debridements for arthritis.
How do you determine, how do you keep, like a person that develops scar tissue a lot?
Yep.
How do you keep them from developing scar tissue?
After the surgery. So that is when the therapy comes in. So everybody makes scar tissue. Some people, make more than others. And if it's your first surgery, you don't know to what extent. The biggest thing is getting into therapy and doing your therapy and really stretching the scar tissue out before it gets too mature that you can't do it anymore. So that's when it kind of falls on your shoulders to do the therapy. Because, see people come in, I see everybody a month after surgery. And if they're barely moving their knee, and I'm like, well, where are you doing therapy at? They're like, oh, I haven't started yet. I'm like, that's not good. We told you to get into it the moment you left the hospital, and the therapist told you 10 times. It's written on all your paperwork. I told you before surgery. So, there's an element of taking some ownership of what you're getting into. That's why having a good support system and cast around you is important, because you're going to be nice to have some help. So, yeah.
Do you have to walk with a walker?
We start everybody off the walker. A lot of that's for safety too, just you're not falling here. But when you get home, most people stay with a walker, and as you're working with your therapist, they may graduate you to a cane. Around your house, you may not be using anything, or then you start forgetting where you put your cane, and then you don't need it. Definitely at the beginning when you're going, like say you're coming to an office visit, and you don't know where you get to park in a big parking lot, I would recommend a walker or cane just because the distance, you don't know where you're parking. Or if you're going to the mall, people tend to stay away from people with a cane and a walker, so you can kind of use it to say, don't come by me. So, they definitely help. Ambulatory aids, you use it in your other hand, you can take weight off and things, so yeah.
At what point do we get to you? Like, does the primary care doctor send us to see two other people?
Not necessarily. Your primary care doctor definitely can make a referral to obviously come see me. You can also, I believe, just call OrthoIndy, and if you know my name, you can say, can I get an appointment with Dr. Pomeroy? Because if you just call and say my knee hurts, I'm not the only person who sees knees, so you may end up with someone else that's probably perfectly fine. They're all good here. But if you wanted to see me, you just tell them my name.
So you're not just the surgeon, you're...
Nope, I get to meet people too. Yeah, so I do injections, I prescribe medications. Yep, I answer emails, my email's on the card. So yeah, my phone buzzes all the time.
Are you hip
You want
knee
it-
specialty then?
What's that?
Are you hip knee specialty?
Yep, so that the fellowship when I moved to Charlotte was just specifically to do a whole year of hip and knee replacements with people teaching me. So I do hip and knee replacements, then I do a different talk, but a lot of the revisions, so redo hip and knee replacements. So I will switch over. It won't probably take as long just because it's arthritis is arthritis, but we'll talk about the hip. So there's my stuff. That's what I was talking about, the middle part, the fellowship part. So if you go to see an orthopedic surgeon in a bigger city, probably did a fellowship. If you're in a smaller town, they may just be residency and then just went out to be the general orthopedist, and they may see your wrist, your spine, your foot and ankle, and your knee. But if you come to any kind of metropolitan type area, there's specialists, generally speaking, nowadays. So, the hip is a little different. So like you see here, it is a ball and a cup. So this is, the hip's not as common, that's why I did it second. Still arthritis is obviously one of the most limiting factors for disability. The anatomy of the hip, ball and socket. So the ball would be the top part of the thigh bone. We call it the femoral head. That would be this ball up here, actually a ball. The cup is the cup in the pelvis. It's actually called the acetabulum, but it's a ball and a cup. And it acts like a ball in a cup. So you just put it in, the ball goes in the cup. So that's how you replace it. But it's this, for the same reasons. And you can see on that video, so I'll go back, you know, here it goes. But it's not sliding and slipping and twisting and all. It's a ball that just has the 360 degrees of motion, but the ball always stays inside the cup. It's not gliding in and out. You know, you'll see people and they're like, I feel like my hip's popping out or sliding out. If your hip really did pop out, you would be 911 going to the emergency room or something like that. So it doesn't just kind of slide in and out. So common reasons, obviously, like we said, osteoarthritis, same deal, just kind of wear and tear would be primary osteoarthritis. You know, once again, it doesn't get better, it gets worse. You can kind of see the picture here, arthritis, the cartilage you can see is kind of pink and worn out. There are some people you go in there and they have zero, right, bone on bone, and it just looks like it looks like marble instead of a nice kind of soft, cushiony, like white surface. It looks like hard marble that almost has light reflecting off it because all the cartilage is worn out. So there's a picture there at the top of a healthy hip with good cartilage would be that pink stuff on there. And then down at the bottom with no cartilage, it's just kind of all worn down. It can be deformed. Some people, the ball becomes more like a peg. So you've got a peg and a round cup. That doesn't work very well. That's when people get really stiff. They can't get their shoes on. They can't lift their leg up. Can't do things like that. So, you know, here's this kind of fun fact, I guess, right? By 2030, estimates 67 million adults will have arthritis. The population is aging, so limitations from arthritis is a real thing. And we talked about this. Arthritis is the same in the hip and the knee. It's shaped differently, but the cartilage is the same. The fluid that lubricates, it's the same. Here's the same kind of reasons, you know, age, weight, like we said, diabetes. Treatment pathways are the same. So patient education, assistive devices, then you can get into Tylenol, ibuprofen. Obviously there's prescription strength anti-inflammatories that your doctor or I can send over for you. That's another question you'd have to ask your family doctor. Can I take ibuprofen? Because if they say no, and you come see me and then you ask for an anti-inflammatory prescription, and I don't know that, I can't give it, I shouldn't give it to you just because it could hurt your kidneys. So you gotta kind of know if you can take that stuff. Joint injections, typically here we don't do the gel, the hyaluronic acid injections in the hips, usually just cortisone. The knee injections we can do in the office, pretty easy, doesn't hurt. No, cold spray, it's easy. The hip injections, because I can't feel your hip, we send you to our physiatry doctors, another specialty. They use an x-ray machine, put the tip of the needle in there and inject a little contrast dye to make sure the needle's in the joint, and then they inject the medication so they know it's in the right place. So it is more of a procedure to get a hip injected than a knee injected. Once again, obesity, it's kind of a never-ending circle. So same thing, we kind of talked about this, medications, Tylenol, anti-inflammatories, and then surgery. So this is kind of what a hip replacement looks like. So you've got to replace the ball, and you've got to replace the surface of the cup. So in order to do that, we use 4 pieces. You replace the stem, you put a stem down the inside of the thigh bone, because you have to have something to hook the ball to. So that acts like an anchor inside your thigh bone. So your thigh bone's actually hollow like a PVC pipe. So we put the stem down in there, and then your bone grows onto the stem. That's the kind of the anchor for the hip ball. The new ball can either be pink, which means it's ceramic, or it could be shiny silver, which means it's metal. That's the two kind there are. And then you put a metal cup, which I have up here, a metal cup inside your bone, and the bone grows onto it. But then we snap, just like in the knee, we snap a little plastic liner inside the cup, and that acts like the new cartilage inside there. So the actual bearing surfaces that rub against each other is just the ball and the plastic. You need the metal pieces to anchor it into the bone. So just like a knee, there's 4 pieces that go into a hip replacement. A total hip replacement, I should say. So like we said, there's a new ball, the bearing surface, the liner, and the stem. This is kind of just a schematic here. Healthy hip, like we talked about, with the knee on the left. See the good cartilage, arthritis in the middle with the cartilage worn out, and then what a hip replacement would look like. This bone, so you could see that the stem went down the inside. They, cut down the middle of the bone and took the front half off. So they kind of opened it up, clamshelled it, so you can see that the stem would go down the inside. So that's, you don't actually do that to the bone, but it goes down the middle of it.
How long does it go down in there?
So it depends what size, right? So depending on how big your canal is, which is the inside of your PVC pipe, there's a bunch of different sizes. And you start with a small one, and you can use the X-ray machine. You keep going until it's a press fit, and then you're done. Depending on people's bone quality, some people, not as much anymore, used to cement the stem in there. Now pretty much it's all press fit. So we don't use cement in hip replacements. You can or you don't have to in a knee, but you usually don't in a hip. So the length of the stem usually grows as it gets wider. It's kind of proportionate. So like I said, there's different bearing surfaces. These are really the two that you would run into. Would be ceramic, which is pink, on plastic, or used to do ceramic on ceramic. That's not that common anymore either. The ceramic on ceramic, if you know someone who has a squeaky hip, or read about a squeaking hip on, like you can hear them walking down the hall, that's typical of a ceramic on ceramic hip. So, yeah. So we can go through these. Different approaches, you may hear about these or read about them. There's a bunch of different places you can put your incision. On the front, it's kind of the newer way to do it. It's not really that new, but it's the newer way. So that's called an anterior approach. You go straight down kind of through the front. Your incision's more right off to the side here. That way you don't cut any muscles. You go in between them. People usually recover quicker, require less pain medication, things like that, because you don't cut any muscles. If you go in on the side of the hip, over here you've got to get through your butt muscles and everything, so you've got to go through them to get in there. So usually a little more pain with that. Traditionally, if you went in from the side, you'd be laying on your side for surgery. This is what it looks like if you're going from the front. So there's a special table. We have a few of them back there. And you're asleep on your back, so you're not on your side. And we go straight down through the front, and there's these funky looking ski boots on you, so you can move your leg around. We can rotate your leg, move things around during surgery to measure lengths and everything. That's a little history of it, but obviously anterior approach, like we said, less trauma, may have a smaller incision, less pain. You don't go through any muscle, so less tissue disruption. And you don't have restrictions as much after surgery. So if you go from the side, they may tell you don't bend past 90 for 3 or 4 months, don't twist and do that. If we go in from the front, we don't really put restrictions on people. So recovery, this is a big difference between hip and knee. You can literally recover on your own. A lot of people don't do formal physical therapy. The best therapy after hip replacement is just walking. It's not like your hip's going to get stiff. Like a knee definitely can get stiff. If you want to do physical therapy, we're more than happy to prescribe it for you. But you don't have to if you don't want to. A lot of people go home with a home exercise program, meaning our therapist showed you some things for 1 or 2 sessions, and you just do that and walk. Wound care is the same. We glue the incisions, same rubber Band-Aids, so you can shower when you get home. Stays on for 2 or 3 weeks. So you shouldn't have any staples or stitches to come out from a hip replacement either. In the end, like we said, is it right for me? It's all elective. There's no emergency hip replacement surgery unless someone broke their hip and they need something in the emergency room. But if you're coming in for arthritis, it's not an emergency. And then once again, do I have a shorter leg? You can change leg length with a hip replacement. Balance problems. Is there pain? Typically, as A lot of doctors don't know this. If you have pain in your groin and you can't spin your foot in and out, that's probably your hip joint. If you come in with pain in your buttock, it's probably your back. If you have pain on the side of your hip, it may be bursitis. So hip arthritis typically presents with growing pain. Obviously, same little things. And if you answered yes to any of these, you might need to talk to an orthopedic doctor or get some x-rays. And then some references. But are there questions about hips?
Just have one general question. You keep saying that it's elective, but insurance covers it.
Yes, insurance covers it, yep.
Okay.
Yep. So an insurance may say no if you've never taken an anti-inflammatory. You've had pain for 4 days. You've had, generally speaking, if you come in to get a surgery, you've probably had, if you're having surgery, probably pain for greater than 6 months, gone through a couple anti-inflammatories. You don't necessarily have to have injections. Some people just don't like needles and they're like, I'm not doing that. So that's not like a requirement. Maybe you've done some therapy. Maybe you're using a cane, that kind of stuff. So by the time we get to talking about a hip or knee replacement, pretty much all of them get approved. And we would definitely never do the surgery unless it was approved. So it's not like we just accidentally do it and then say, oops, it wasn't approved. So.